This conference will now be recorded.
Hello, everyone. Welcome, welcome. My name is Susan Hayes, and I'm a clinical health facility surveyor. I've been a surveyor for 10 years, and I've been with the training department, training our surveyors for the last 3. I'm going to talk to you a little bit right now about activities and social services is what we're going to go through. These are both very important in our nursing homes, especially in this day and age of COVID. Our activities are especially important. We've got to keep these people involved and make them feel like they're worth something and not lock them away in their rooms and with nothing to do. So we'll go ahead and get started. So the activities tag is F679. And basically, it says the facility must provide, based on a comprehensive assessment and care plan and the preferences of each resident, an ongoing program to support residents in their choice of activities, both facility-sponsored group and individual activities and independent activities, designed to meet the interests of and support the physical, mental, and psychosocial well-being of each resident, encouraging both independence and interaction in the community. You're going to find that a lot of our quality of life and quality of care tags all say based on the comprehensive assessment, which is the MDS, and the care plan, which everybody has to have a care plan, and everybody gets a comprehensive assessment or an MDS at least quarterly. And you want to make sure that these things are looked at as you're designing your activities for each individual resident and for the facility as a whole. So in 2019, the activities tag 679 was cited 10 times by the state surveyors. Now that doesn't seem like a whole lot whenever we have 300 plus nursing homes, but those 10 episodes had the potential to affect over 500 residents. As we'll find out in a little bit, the tag can actually be written for just an individual resident. So if one individual resident in a home was cited for activities, every other resident in that home had the potential to be affected by that deficient practice. The interpretive guidance, the intent tells us that it is to ensure the facilities implement an ongoing resident-centered. That's all new language. Everything now is all resident-centered. It should be according to what the resident wants. Activity program that incorporates the residents' interests, their hobbies, and their cultural preferences, which is integral to maintaining or improving their physical, mental, and psychosocial well-being and independence. Basically, to create opportunities for each resident to have a meaningful life by supporting his or her domains of wellness. And those domains are security, autonomy, growth, connectedness, identity, joy, and meaning. CMS did a survey of nursing homes a few years back and wanted to know what they needed in their life to make them feel as though they were actually residents in a facility and not a resident in an institution. And their biggest thing was they needed to have something that gave their life meaning. They wanted to be able to continue with some of the things that they had done in their previous life, their hobbies, those types of things. And they needed something to let them know that they were still important and that their life still had meaning. And that's why it's so important whenever you're putting together your activities, care plans, that these things are all looked at. Some of the reasons that we cited these deficiencies in 2019 was the failure to provide ongoing activities, especially on the weekends. I believe the regs say that they are to have 2 activities Monday through Friday and an activity on the weekend. Now, these don't have to be the big group activities where you're sitting down and doing crafts on the weekends, but there must be something on each one of those days that the residents can be involved in, whether that's a movie and popcorn. We used to say that we really didn't feel like church services were activities, but they can be considered an activity. And you need to try and make sure that all of the residents are aware that these things are going on and can participate if they choose to. The facilities also fail to provide activities to cognitively impaired residents. This is very important. These cognitively impaired residents need something to keep them busy and need something to stimulate them. And sometimes those one-on-one activities are exactly what's needed. They fail to provide activities to residents who are dependent on staff for activity needs. Just because a resident's had a stroke and can't use their hands doesn't mean that they can't be involved in some of your group activities. We all know that bingo is the #1 activity in the nursing homes, and we have residents that really become upset if we don't get to have our bingo games. And sometimes these residents that are dependent on staff to help them with this should still be allowed to be involved in that bingo game. You may need to find some volunteers or a staff to come in and move those chips for that person, or help them find the numbers on the cards because their vision is really difficult to see what's on those cards. They fail to inform of activities occurring. This is one of the biggest things I think that we find, is that even though you put out a monthly activity calendar, let me tell you, sometimes my vision is not the best and it's hard for me to read what's on there. And if you've got other residents that have a little bit of difficulty seeing, they can't always see what's on there. And sometimes those maps and those activities charts are placed in areas where they can't even see them if they are in a wheelchair. The failure to provide one-on-one activities, these are probably the ones that you're going to need to do most with your cognitively impaired residents, or those residents that aren't able to get out of their bed or they're room bound. Failed to develop a care plan for activities, and failed to provide activities to residents who are bed chair or room bound. No matter what, every resident needs to have some sort of an activity, and they don't have to be big, elaborate activities. They can be small, and they don't have to last 30 minutes apiece, especially for your one-on-ones. So let's look at a few definitions when we're talking about activities. So an activity is any endeavor other than ADLs intended to enhance well-being, physical, cognitive, and emotional health. So we can't say that an activity is to put somebody in the whirlpool. That's not an activity, that's actually an ADL. But we can say an activity could be having a couple of little ladies get together and painting their nails. One-on-one programs are those provided to those who will not or cannot effectively plan their own activity pursuits, or for those residents needing specialized or extended programs to enhance their overall daily routine and activity pursuits. These are those residents that are in their room alone, and or are little cognitive residents that you can't keep seated at a bingo chair, or that wouldn't understand how to play bingo anyway. These are the residents that need a little one-on-one time for stimulation to keep them involved in an activity of some sort. Person appropriate. This is the activities are relevant to the specific needs, interests, cultures, backgrounds of this person. You need to find out everything you can about this person. What did they do as a living? Did they have special interests that they were involved in? What about hobbies? Did they knit? Did they like to fish? We'll talk about fishing in a minute. Did they like to fish? Did they enjoy horses? Do they have a special TV program that they have to watch every single day? What about their cultures? Is there something in their culture? Are there some holidays that we normally don't celebrate that could be important to these residents? And then we have our program of activities, and that's a combination of large and small groups, one-on-ones, and then self-directed in activities, which a lot of times we call independent activities. These are things that the residents like to do on their own, such as sitting in their chair and knitting, or you're going to see there a lot of our residents now like these mandala color books where they can color and they can spend hours and hours on time just coloring in these books. Not the young kids coloring books, but the mandala coloring books. So all of the residents need an assessment whenever they first come in. The activities director should be doing a resident assessment within the first week to two. And a lot of that should be going into the MDS. So you're going to need to make sure that you find out as much about these residents as you can. You want to find out what are their lifelong interests? Do they have a preference? What do they prefer to do? Are there adaptations needed? Those type of things. You know, find out, do they like country music? Do they like gospel music? And if they do, why do the surveyors always find MTV on their TVs and the music that they're listening to? Care planning. Let me just go back to the assessment for just a second. The surveyors are looking for 4 things to determine whether or not we have a deficient practice. One of them is the assessment. So we always look for an assessment. We look for a care plan. And if it was implemented, we look for whether or not monitoring and evaluation of those interventions are accurate for that resident, and we look to see if the facility is revising. That's what we call ACER, ACER, Assessment, Care Plan, Evaluation, Revision. So we just talked about the assessment piece, so let's talk about the care planning piece now. So information from the individual assessment is used to develop the activities component of the comprehensive care plan. That's the assessment that the activities director has gone and done, and with that resident, so that they should know little minute details about exactly how they can come up with a plan for that resident. Plus, it also should incorporate pieces of the MDS. The objective should be measurable and should focus on the resident's desired outcomes. What does the resident really want? Do they want to be able to go to the meetings, to go to the group activities, or do they really want to just sit in their room and watch TV and be left alone? All relevant departments should collaborate, not just the activities department. So activities is actually kind of putting that care plan together, but they need to talk to the CNAs, talk to the nurses, talk to the kitchen, talk to housekeeping, anybody that may have had communication with this resident, so that they can determine exactly what it is that this resident can do, wants to do, and possibly will do. So remember, activities can occur at any time, not just during formal activities provided by the activity staff. So this is where the activity can be in the resident's room with the one-on-one, where sometimes all it takes for an activity is to go in and massage lotion on the resident's hands as you talk to them. And that's stimulation. There are activities, those people that like to color, that's an activity. If they like to make sure that they always see the Price is Right at 10 o'clock, make sure that they are somewhere where they're always seeing the Price is Right at 10 o'clock. So we need to look in your care plan. You need to think about accommodations for these residents too. Look at their schedules, at the supplies and the timing to optimize participation. For somebody that likes to watch Price is Right at 10 o'clock, let's make sure that we don't have their bath scheduled at 10 o'clock. You might have to modify their meal schedule for an activity. Assist the residents in dressing, toileting, and transportation. This is another big area that the surveyors really look for. Ours is somebody walking in those rooms, telling that resident, this activity is fixing to happen, would you like to go? Making sure they're dressed, making sure they're toileted, and helping to get them down to that activity. This seems to be one of the biggest things. A lot of these residents can't get around the facility by themselves. So if somebody's not there, making sure that they are dressed, they're clean, even if they have to wear incontinent briefs, are those incontinent briefs clean? Or they're not saturated, so whenever they get down there, they become embarrassed because it soaks through their pants? And are they getting the transportation needed to get to those activities? Need to make sure that you have enough supplies and adaptive equipment for anything that's needed. Talking about bingo, adaptive equipment, how many of you have seen the great big cards that are about like 1 by 2 feet and they have the big numbers? And those are the types of things that you can look at for your adaptive equipment for some of your activities. So individualized interventions are based on each resident's history, preferences, strengths, and needs. Make sure that you're individualizing each individual resident's care plan for that resident specifically. So reality orientation and large group activities that include residents with different levels of strengths and needs are not necessarily recommended. You can try and set those little residents down that are confused, that have dementia, and you're not going to orient them back into reality. It's really not something that is even should be attempted. Let them live in their own little world. They have a mission for what they're doing in their own little minds, and you can't change that. Your large group activities, you want to make sure that if you're fixing to do some crafts that maybe are going to include some fine motor movements, that you have somebody there that can help those residents that don't have the fine motor to complete those little pieces of the task in the craft. Always think about what everybody needs and what they can do. So when evaluating the provision of activities, it's important to identify whether the resident has issued for which staff should have provided adaptations. So should the staff know that they have vision problems? Make sure they have their glasses on before they go to activities. Do they have hearing problems? Are hearing aids in? How about those physical problems, your fine motor movements, your large motor movements, their cognitive status? All of those types of things need to be taken into consideration whenever you're designing their interventions for their care plan. So you do have those residents that have behavioral symptoms, and activities can actually help decrease those symptoms. The facility should take into account their pattern of the behavior. For an example, there was a little gentleman in one of the homes, and he used to start pacing about 10 o'clock in the morning, and he would walk the halls and walk the halls, and he'd go in and out of rooms, and he'd walk the halls and walk the halls, and was just beside himself. Well, come to find out, after they talked with the resident's family, he had been a postman, and he knew that his job that day was to deliver the mail. That's what he had done for years and years, and he was lost not being able to deliver the mail. So whenever whoever delivers the mail in the facility it came time to do that every day, they let him go with them and they handed him the envelopes and he handed it to the residents. And those behaviors stopped because even after that 15 or 20 minutes of delivering the mail, he didn't have to wander then for the next 6 hours wondering what he was going to do. Another example, we had one of the homes had a little resident that every day at 2:30 she would try and get out the front door. She would try and get out the side doors. I mean, she was bound and determined she was getting out of this building. After somebody took a little bit of time to find out what happens around 3 o'clock every day, 2:30, they found out that she was the one who always went and got the grandkids from school. And she was in her dementia mind, she had to go get those grandkids. And once they were able to get her to doing something else, then she didn't have to go find those grandkids and go get them. And she didn't, then that elopement risk became almost nil. And I believe what they did with her was they got her involved in sorting washcloths and folding washcloths, a basket full of washcloths about 2:30 every day. And then she became just fine. And they might even tell her, oh, your son called and said, don't worry about it, he's picking them up today. But then that basically that behavior went away. And the activity should always be presented prior to when those symptoms usually present themselves. If you watch, you will always, there's always something that happens about that time that those behaviors start. And the reason why these should be started before then is because once a behavior escalates, the activities may be less effective and they can actually cause further stress if you're trying to redirect them away from the activity that you want them to be redirected from. So examples of interventions to address behavioral symptoms include encouraging physical exercise for a resident who's constantly walking. Well, you think constantly walking is a physical exercise, but try and get them involved in the actual exercise program in the mornings if you have one. Providing tasks for residents who go through other belongings. Once again, that laundry basket full of washcloths to fold, carry it away, unfold them all, bring them back and let them fold them all again. That definitely helps to keep a lot of residents out of other people's rooms. Offering social programs and opportunities for leadership for residents who's attention seeking. One facility had a lady and she just, nothing was right. They could never, ever satisfy her. She complained about everything. She called the state every time you turned around with a complaint on the facility. And come to find out, she just was feeling like she didn't have a place. And they developed a welcoming committee, and they put her in charge of the welcoming committee. And now she had a place and she had a reason for being there, and those behaviors stopped. She had a reason to be in that facility and she had a job to do. And that's all it took, was just allowing her to have a little piece of control of something, and being in charge of the welcoming committee just made her happier than all get out. So when we're looking at determining if the facility has an ongoing program of activities designed to meet those individual needs, we look at several different things. And of course, the objective is to determine if you do have a program. So these are the things that the surveyors look at. We have what we call ROI, record reviews, observations, and interviews. And these are the things that the surveyors are going to be using to determine whether or not the facility is in compliance with the activity regulations. So the facility is going to be seeing if the staff take preferences and needs into account. Like I said, if we see that they like Western music, but they have MTV on their, or it's not MTV, it's yeah, MTV on their radios or their televisions, then we know that nobody's paying attention. Are they using adaptive equipment? Are they providing timely transportation? Like I said, that's one of the biggest things that we see lots of residents just sitting in their room during activities that would like to be there. And are they providing activities that are compatible with their interests, needs, and abilities? We're going to interview. Interviews are a big piece of the investigation. We are going to start with the resident. All the residents that we have on our sample that we look at whenever we do a survey is ask questions about activities. And if they can't answer, then we go to their families to find answers. And we want to know their opinion of their activity participation, whether it's important to them or not, and if the activities are individualized according to what they like. And we do have those residents that say, you know what, I really don't want to be involved in anything. I just want to be left alone and I want to sit in my room and watch my television, and that's my choice. And those residents have that right to that choice. And what you need to put in that care plan is the resident prefers to stay in his room and watch television, knowing that still you can still let him know, hey, we're going to be doing this today, but it's okay for you not to have a big massive activities care plan for residents who are cognitive and can say, I don't want to participate, just leave me alone. So which staff should be interviewed? Well, we're going to be talking to the activity staff. We're going to be finding out how does she do her evaluation, her assessment whenever the residents come along. How often does she redo it? What kind of things does she take into consideration whenever she develops the care plan for individualized resident interventions and for group interventions? We're going to be talking to the nurse aides. They're the frontline workers, and they're the ones that interact with these residents more than anything, and they can probably tell you a whole lot about what these residents' histories are, what these residents like to do, and what the residents can and cannot do. We're also going to be talking to the social services staff, and we're going to be talking to the nurses to see what they know about their activities and the residents' abilities. So for our record review, we are going to be looking at that assessment that the activities director does. And we want to know, did the facility find out about the residents' past life activities, their choices, their preferences, and any needs for adaptations? And then what do the records indicate? So if we can walk into a room and sit down for 5 minutes and find out that this gentleman was a mailman and that he loved to fish and he likes to watch Western movies and he enjoys listening to gospel music, then and that he needs assistance with some vision because his vision is starting to go away. We think that the facility should probably already know that, and we think that the activity director's record should indicate that. We're going to be looking at the care plan. We're going to review the activities component of the comprehensive care plan to determine if the resident participated in its development and if that plan matches the resident's interests and goals, and if it specifies who provides the needed services. Some activities, you know, the one-on-one activity with the moisturizing and moisturizing of the hands and the arms, and just sitting and visiting with the resident, that doesn't have to be done by the activity staff. One of your CNAs can do that. And we're also going to determine if the facility periodically reviewed the plan with the resident input and made any needed changes. Maybe that resident who was knitting all the time now can no longer knit because her arthritis has become so bad that her hands are now starting to gnarl and she's unable to hold the knitting needles. Is there something else that we can do to help her, or any changes that need to be made to that plan? So for activities, in order for us to determine if there's compliance or not at the facility, the facility will be in compliance if they, 1, recognized and assessed for preferences, choices, specific conditions, causes, and or problems, needs, or behaviors. That's where that assessment comes in. We're going to go right here. We're going to do our ACER again. Did they assess? We're going to look and see if they defined and implemented activities in accordance with their needs and goals. That is basically designing your care plan and implementing your interventions that you put in that care plan. We're going to see that the facility monitored and evaluated the residents' response to that care plan. And we're going to see whether or not they revised approaches as appropriate. And so if the facility did all 4 of those things, they assessed, if they care planned, if they evaluated, and they revised, then they are in compliance. So determination of compliance is going to be done separately for each individual resident sample. And I can tell you that right now, the majority of our homes, when we do a recertification survey, they're sampling about 30 plus residents. So we're going to be looking separately at each resident. So if one resident had an issue with one of those 4 things, if a proper assessment was not done for one resident, then the facility can be cited for that one resident. It does not have to be an overall situation. But remember, like back on the very first slides, that one resident, if there's an issue with one resident, there could possibly be an issue with all residents. Activity interventions must be individualized to the resident's needs and preferences. We've discussed that quite a bit. What do they want to do? What can they do? So let's talk about our fishing here just for a second. We know that you cannot put 4 or 5 gentlemen into a truck and take them out to the pond and go fishing. But let me tell you, there was one facility that I was in, and the residents just wanted to get out and go fishing. They just, well, then just take us to the park and let us sit and throw a cane pole in. So what they did was they went and they got with a big country store who donated them a big cow watering tank. They found a hatchery that had some fish. They brought the tank in, they put the water in it, they put the fish in it, and they took them out in their wheelchairs and let them fish out of this tank. And those residents talked about that for months and months. So little things like that can be done. You just have to be ingenious in what you're looking at and what you're doing. Now, of course, that's a group activity, but hey, even the ladies got in on the fishing. The facility must also have provided necessary adaptations to facilitate the residents' participation. So we're going to be looking, did you make sure they had their hearing aid in? Do they have the big bingo cards? If not, is somebody sitting there helping them? Did they have the bigger scissors if they're able to still cut? Did they have all those types of situations? Any adaptation that needs to be done. So the new guidance from CMS back in 2016, when they totally changed the tags and everything on us, they brought out what they call psychosocial harm. Of course, we've always had psychosocial harm, but they've really started to put into play, you really need to look and see whether there was psychosocial harm to these residents. And that's for the quality of life tags and the quality of care tags. It also pertains to other tags, but these are the ones that we especially look at psychosocial harm. So if there is a problem with the activities tag, did it possibly psychologically harm the resident? So once the team has completed their investigation, they've analyzed the data, they reviewed the requirements, and they've identified any deficient practices, then they have to determine the scope and severity of each deficiency based on the resultant harm or potential for harm to the residents. The survey team must consider the potential for both physical and psychosocial harm when determining the scope and severity of deficiencies related to activities. Now, you wouldn't think there could necessarily be a whole lot of physical harm with activities, and probably not a whole lot of psychosocial harm, but it can be. And the physical usually becomes about because of the psychosocial. When that resident is not given the opportunity to be participating in the group activities that they want to be, they become depressed. And when people become depressed, then they stop eating, they stop trying to take care of themselves, which then brings about the physical harm. So we really need to stop and think about that. And if it's determined that the facility has failed to comply, then depending on the negative level of effect to the residents, the team may actually determine that the scope and severity reaches a harm or immediate jeopardy to their level. If you just have, if the resident really they don't find any harm, then you probably have like a level 2 deficiency. If we find that they're starting to show signs of depression, or it's gone even beyond that, then we may have some harm here. And so it would rise to that level 3. And if it's to the point where this little resident is talking, they want to kill themselves because they don't have anything worth living for anymore, we may actually look at taking it to an immediate jeopardy level, which is level 4. So let's just look a little bit at some of these deficiencies. When we look at deficiencies, we want to know, and when we're trying to determine, were the deficiencies avoidable or were they unavoidable? If they're avoidable, that means the facility failed to do something. If they're unavoidable, then the facility did everything that they could, but it still happened. And those things do happen. So when we're looking at this, was this an avoidable situation? So we have a resident who needs assistance to get back and forth to the activities. They enjoy socializing and conversation with other people, and they also enjoy watching TV. While the surveyors were on site, they noticed several activities were going on. They had a hot chocolate activity in the dining room, bingo in the main dining room, and a Christmas movie social in the main living room. Every time that any of these activities was going on, the resident was observed in her room. So the surveyor asked, would you like to participate in the activities? And she said, yes. Did the staff invite her to the activities? No. Asked if she would like to be up and out of her room, and she said she would. Is this an avoidable deficiency? Yes, it is, because the facility failed to get her to the activity when she really would have liked to have been there. Here's another one. An activity care plan documented the interventions to provide music in the room, the resident to attend at least one new activity before the next review, to encourage the resident to continue to come and tell her what a great job she's doing, and to observe the resident and visit the resident for new activity ideas. So on 11/4, she was observed in her room sitting in the recliner. She was in there all alone. There was no music playing. The room was dark and quiet, and nobody was observed to come and ask her if she wanted to attend the manicures. Nothing else was done. At 11:29 the same day, she was still observed in her room, covered in a blanket, asleep. There was no music playing. The room continued to be dark and quiet, and the activity for one-on-one was scheduled for 11:30 and nobody showed up for the one-on-one activity. Then an activity of bingo was scheduled at 2:30, 2:37. She's now sitting in the chair in the hallway and nobody offered to take her to bingo or encouraged her to attend, and nothing else was provided. Was this an avoidable deficiency? Yes. Once again, nobody bothered to make sure that when she was in her room that she had something to stimulate her, that she had at least her music going, and nobody bothered to try and get her to attend the activities in the facility. So now we have a resident who enjoyed news, group activities, and going outside. No time were they engaged in the activities, even though activities were occurring at times during the observation. The activities director reported she did activities 3 times a week with the resident, but could not report what those activities were. Is this avoidable? Most definitely. If the activity director is doing activities 3 times a week with the resident and she can't tell you what she's been doing, then she probably hasn't been doing anything. And we have a male resident with tendency to isolate who was offered no activities during the survey. When the activities director was asked about the individualized activities, she stated she blanked out when it came to activities for men and didn't know what to offer. She stated she'd have to go look at some bookwork. Was this avoidable? Yes, she basically came right out and said, we haven't been offering activities because I don't know what to offer. So now we have the activities director. And our activity director tag is under F680. And the intent is to ensure that the activities program is directed by a qualified professional. So what does being a qualified professional entail? Well, they must be a qualified professional who is a qualified therapeutic recreational specialist or an activities professional who is licensed or registered by the state in which practicing, is eligible for certification as a therapeutic recreational specialist or as an activities professional by a recognized accrediting body, has 2 years of experience in a social or recreational program within the last 5 years, which one of those was dealing with full-time patient activities, is either a qualified occupational therapist or has completed a training course approved by the state. So as you can see, the activities directors range from college degrees to completing a training course approved by the state. Because all of those are or, not and. Most of our activity directors in the state of Oklahoma have just attended the approved training course by the state. So the responsibilities of that activity director is to direct the development of the program. And then they need to complete and delegate the completion of the components of the comprehensive assessment and contribute to the comprehensive care plan. So directing the activities program also includes scheduling activities, monitoring the reactions of each resident to the care planned activities, and then revising those interventions as necessary. The activities director is the main person that needs to follow that ACER, assess, care plan, evaluate, and revise. So the facility is in compliance if they have employed a qualified activity director who has developed an activities program that meets the interests of the residents. If that activity director ensures the activities component of the comprehensive assessment is completed for every resident and contributes to their care plan goals. And if the activity director monitors residents' responses to interventions and has made necessary changes to care plans and or to the program offerings. So as you can see, activities is very important. And like I said earlier, especially in this time of COVID, we have to keep these people engaged. We have to keep them stimulated, or they're going to all become extremely depressed. And we know that that's going on right now in the facilities. And make sure that we're doing everything that we can to keep their lives as normal as possible. So now let's move on to social services. I'm not sure how many of you have been previous activity directors or have been social services directors in our nursing homes, but these often go hand in hand. A lot of the nursing homes, the activities director is also the social services director. And it can sure become time consuming. And sometimes those job descriptions kind of overlap. So when we're looking at our social services, that tag is F745. So in 2019, it was only cited 8 times. But like the activities, these 8 episodes of deficient practice had the potential to affect over 350 residents. If one is being ignored, are all being ignored. So the regulatory language states the facility must provide medically related social services to attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident. The intent is to ensure that the sufficient and appropriate social services are provided to meet the residents' needs. And social services, as we'll find out in just a few minutes, is a wide range of services. So medically related social services examples are, and here we go, we're going to get started on this big long list, and this is not all inclusive. These are just tips of the icebergs. Making arrangements for obtaining needed adaptive equipment, clothing, and personal items. There's several times that we have surveyors have gone in and found that residents have 1 or 2 pieces of clothing in their closet. And basically while one is in the wash, they're wearing the other, and then when that one goes to the wash, the other one comes on. These are things that the social services director could help make sure that these residents have more than just one change of clothes. They're also the ones that are going to be involved in getting their adaptive equipment if needed. This is probably the person that's going to be working with the DME companies to get the wheelchairs, to get the walkers, those type of items. Probably in case somebody needs some feeding utensils, that the plates or the silverware, the weighted silverware, the social services person probably will be involved in that. They're also going to be maintaining contact with the facility to report on changes in health, current goals, discharge planning, and encouragement to participate in care planning. So they're kind of the go-between the resident and the facility on a lot of things. I had one little resident tell me one time that their social services director was like the mama of the house. She's the one that takes care of all the things that need to be taken care of. So that's kind of where they look at what social services is supposed to be doing for them. If they had a problem, they'd go to social services, and somehow or another, she'd take care of it or tell them why she couldn't. Social services should assist the staff to inform residents and those they designate about their health status and healthcare choices and their ramifications. If a resident is refusing a treatment, if they are refusing anything, then it probably wouldn't hurt to have social services also involved with the nurse and the physician whenever they're discussing the alternatives for that resident and the ramifications of whatever choice they're making. They're to make referrals and obtain services from the outside entities. These may be the people that are actually going to be calling the outpatient psych services that come into the facilities to work with behaviors or depression. They're going to be assisting residents with financial and legal matters. Should be. Um, they should be helping with discharge planning services for those residents that are going to be discharged. Providing or arranging provisions of needing counseling services. There's where our outpatient site comes in. They come in and visit the residents in the facility. Should help identify and seek ways to support the residents' individual needs. What are they needing? And is there something that the facility can do to help meet a need that a resident feels they is not being met at the moment? They should help promote actions by the staff that maintain or enhance each resident's dignity and full recognition of each resident's individual. So whenever they're out and about in the facility, they should be watching to make sure that the staff are actually treating these residents with dignity. And if residents have a off culture norm that they follow, and the staff are not familiar with that culture, the social services probably should try and inform the staff about some of those cultural ideas that they can help so that the resident feels comfortable in the facility. They should assist the residents to determine how they would like to make decisions and finding options that meet the physical and emotional needs of each resident. They should provide alternatives to drug therapy or restraints. Just if you have a behavioral resident, social services should be involved. You shouldn't just be picking up the phone and calling and getting a psychotic medication to give to a resident or putting them in a wheelchair with a lap buddy on. They should be trying to figure out what else can be done to help these residents with these behaviors. Should be meeting the needs of the residents who are grieving. Some of these residents have lived together for years and years. And when the roommate dies or one of the residents down the hall dies, these residents grieve as if it's their own family. And they should be involved with these residents in making sure that they're able to work through the grieving process, not only for facility residents, but for their residents' families who are outside. They should be advocating and assisting the residents to assert their rights. They should be the one that should be making sure that if they want to vote, that they get the right to vote, and that they can get that absentee ballot so that they can vote. They should be involved in the transition of care services, and when we're talking the transition of care, we're not necessarily talking the emergency trip to the emergency room. We're talking if they're going to be going to another facility or going to go back home, that they should be involved in those areas and make sure that all of those services are set up to help those residents when they get where they are actually going. They should assist the residents with advanced care planning. And that's more than just completing the advanced directives. Talk to them about it and give them instruction in exactly what advanced directives are and the other options that they have. They don't have to have an advanced directive, but give them other options. Assisting the residents in voicing and obtaining resolutions to grievances about treatments, their living conditions, visitation rights, and accommodation of the needs. Like I said earlier, the one little lady said I go to social services anytime I have a problem. And so she should be helping these residents in the facility whenever they're having problems to try and work through those and come up with a solution for those, for both the resident and the facility. So a lot of times, if the social services is not involved, it negatively impacts the resident because they don't get dental and denture care. They don't get foot care. They don't get their eye care. They don't have their hearing services. They don't get the equipment for their mobility and assistive eating devices. And they need a home-like environment with some control, dignity, and privacy. And these are all things that the social services should be involved in. They should be the one that's making the dental appointments and making sure that they're on the podiatrist list whenever he shows up, and the eye care doctor whenever they show up, making sure that all those residents' needs are taken care of. So conditions to which the facility should respond. The social services probably should be involved in any time that resident has a lack of family support. These are the residents that are going to be more able to be abused in the system, and nobody's going to know it because there is no family or support to know that this type of situation is going on. There is nobody for the resident to talk to tell them what's happening. So they really need to be involved whenever these residents lack family or any type of support. They do feel alone now, and they need to know that somebody cares. Anytime there's a behavioral symptoms or problems with the resident, that's social services should be involved, and they should be looking at ways to help those residents. And sometimes it's just that resident may need a one-on-one for a little bit to make sure that they don't get into harm or that they don't harm someone else until the situation can be determined why the behavior is happening and to get the behaviors under control. I know facilities don't like that option because it does cost a lot of money, and we understand that, but sometimes a one-on-one is exactly what's needed for a resident. They need to be involved when there's a chronic disabling medical or psychological condition. When residents are really, really sick, it becomes very depressing. And especially whenever they still have their mind and they know that their body's given up on them, those kind of things can really lead to depression, and the social services needs to be involved with that resident. That's where your depression comes in, the next one. Your acute and chronic pain, they need to be involved in that and finding out along with the nurses what else helps. If we put pillows here or there, what can we do to help with that? And then difficulty with personal interactions and socialization skills. This is a big one, and that's one of those behavioral issues that people want to talk to about being a behavior when it's really not a behavior. It's just that person doesn't understand the need to be socially appropriate. And sometimes the social services person can help guide them through becoming more social and more personal so that they don't quite come off as a behavior problem. They should be involved in the presence of legal or financial problems, at least know what's going on. This is the person that whenever that family's coming in every time they get their $50 and taking the $50 and never bringing anything back in the facility, maybe they need to be involved there. Anytime there's abuse of alcohol or drugs, the social services needs to be involved in that situation. And we are probably going to start seeing a lot more of that in the changing of the generations. We're going to be seeing a lot more of our veterans who have post-traumatic stress disorder that have resorted to the alcohol and the drugs and then no longer can take care of themselves at home. So they're going to be finding their way into our nursing homes. And these people are going to need a lot of special attention. The inability to cope with the loss of function. If you're up walking one day and the next day you have a stroke and you come back and you can't move half of your body or your whole body, think how depressing that would be. And they need to be able to visit with these residents and make sure that they can help them, because this is a grieving process that these residents are going to go to. and they need to help them through that grieving process. The need for emotional support. Sometimes they just need somebody to sit and listen while they cry. And what a better person than the social services. Anytime there's changes in the family relationships, the living arrangements, the residence condition, or the functioning, the social services probably needs to be involved to make sure that everything continues to move smoothly for the resident and to take as much stress off the resident as they can with all the changing relationships in their lives. Anytime there's a physical or chemical restraint, social services should be involved because we don't like physical or chemical restraints, and there's always something can be done to eliminate those two issues. Once again, we talk about the psychosocial harm, and we can also get this to rise to the level of harm and immediate jeopardy. Most of the time, when I personally have written a social services tag, I have had a harm because if for no other reason the resident suffered, and which then suffered usually through pain of some sort, such as dental, those types of situations, they usually, and then that suffering, the pain caused the psychological, the psychosocial. They became depressed. They didn't want to get out and visit. They started becoming loners. And just so you know, they can go to that level, and they, just like the other, they can actually have physical and psychosocial harm from a social services deficiency, and they can rise to that level 3 harm and the level 4 immediate jeopardy. So let's talk about it. If these deficiencies were avoidable, and remember, avoidable means that the facility failed to do something, and unavoidable is the facility did everything in their power and it still happened. And it's okay if it does. If it's unavoidable and the facility did everything, then you won't get a deficiency because you did everything. We understand things are just going to happen. But if we find that a piece of the puzzle was missing and you did not do everything you needed to, then it becomes unavoidable. So in the first scenario, the facility didn't follow up on the placement in a psych unit for a resident who is wandering with behavioral issues. This person was causing fear and anxiety in the other residents, and the social services director wasn't aware of the full extent of their behaviors and thought the nurse who contacted the physician was just doing so because she was tired of redirecting the resident. Well, this is an avoidable deficiency. Why was the social services director not more involved in those behaviors? And if we knew as surveyors that the residents are in fear and are having increased anxiety because of this resident, why didn't she know it? And why would she not attempt to do something more than leave it up to the nurse to take care of business? And if the number 2, the facility failed to give discharge instructions to a resident who needed instructions for Coumadin and insulin administration. They needed instructions on how to obtain lab, on instructions related to dysphagia, which is one of their diagnoses. They were not able to swallow, and referral for home health. And the resident was discharged involuntarily due to non-payment. Okay, this social services director should have been involved a long time ago whenever there was no payment being made. And whenever they finally discharged, this resident was left in a pickle because Coumadin and insulin are not something that you just take and don't worry about anymore. And you have to have your lab results for your Coumadin or you're going to bleed out. You have to have your lab results for your insulin or you're going to go into a diabetic coma. And if you can't swallow and you need home health to come and help take care of you, boy, this ball was dropped all the way around. So this was definitely an avoidable deficiency. The facility did not give a resident a quarterly statement of his trust fund. The facility also did not give the resident notice when the resident was within $200 of the $2,000 resource limit. Was this avoidable? Yes, it was. The facility has to give a quarterly statement of their trust fund to the residents, and you have to let the residents know when they're within $200, because once they reach that $2,000 resource limit, then the Medicaid stops. And then everything has to get started again, and it takes an act of Congress to get it started. So this social services director should have known that this resident was getting close to the limit and done something to take care of that situation. Number 4, we have a resident who's expired, but they did not have their account closed out until 8.5 months after he died. Avoidable? Yes. There is a time limit. I believe it's 30 days. I'd have to get my song back out and look again, but I believe it's 30 days that they have to close out the account. A resident with poor circulation or poor condition of his lower teeth had pain at times. The pain was reported but not acted on. No arrangements were made for dental care, and the facility had not followed up on trying to contact the POA. So here we have a resident who's complaining that they have pain in their teeth, and nobody bothered to try and get him in to see a dentist. And they didn't even bother to call the family to see if they wanted to come and take him to a dentist. So this patient or this resident had physical harm, plus they also had psychosocial harm because of the pain that they were in. This was avoidable. All somebody had to do was call the dentist and find out when they were coming out or get them in to see somebody. A resident did not receive diabetic shoes as ordered. More information was needed from the physician, yet for 4 months, the social service director did not follow up on the status of that information. The resident kept asking, and the social services director and the charge nurse frequently when his shoes would be in. He was repeatedly told they were waiting on the doctor. Avoidable? Yes. The social services director, once found out needed more information from the physician, should have put it on her calendar to once a week to call that physician to find out if that information had been gotten, or to see if there was anything she could do, a form she could complete that only needed his signature, something so that this gentleman would get his shoes. I believe, if I'm not mistaken, this gentleman also developed pressure sores from shoes because he did not have the correct size shoes and was waiting on those diabetic shoes. And so he probably had harm in another area also. We have a resident with the broken and rotten teeth that did not get dental services. The social services director did not follow up on information from the resident about a prior dental visit, and the resident was not informed of the progress of setting up a dental visit. This resident had actually complained about having broken teeth. They let him see the dentist. The dentist said, we need to set him up to come in because we can't do this here in the facility, and nobody bothered to set up an appointment to take him in. And he continued to suffer through pain for the next 3 months and had gotten to the point where he was not eating very much and had lost weight because his teeth hurt so bad. Avoidable? Yes, it was. So something that social services needs to think about is when services are not covered by the Medicaid state plan, the nursing facilities still have to attempt to obtain these services. So for an example, if a resident requires transportation services that are not covered under the Medicaid state plan, the facility is required to arrange these services. And this could be achieved, for example, through obtaining volunteer services. No matter what that resident needs, the facility has taken them on and has taken on the responsibility of their care. And whatever they need, the facility needs to do their best to find the care that's needed for that resident. We have, it doesn't mean that you necessarily have to always pay for everything, such as if they don't qualify for the vision that is under Medicaid and they need a new pair of glasses. It doesn't mean necessarily that the facility needs to pay for those glasses, but social services should have a big long list of people that they can call and say, hey, I have a resident that needs a new pair of glasses. Is there any way that you could come up with a pair? Is there anything that you've got that somebody's returned that are in her prescription that she could have? You need to attempt to get anything that you can get for these residents. I think I went back one, sorry about that. So as you can see, social services does a lot of stuff. And they, whenever you look at everything that they're involved in, they really are like the mom and dad of the facility. They're the go-to person whenever they need something that's not nursing related. And they play a very big role in the facility. So let's look now at what it takes to be a social worker. And this tag is 850. So one thing you need to know here is that any facility with more than 120 beds must employ a qualified social worker on a full-time basis. Now, if your facility is licensed for 120 beds, you have to have full-time, even if you're only using 90 of those beds. So that's something that you always need to think about. Now, for those facilities with 120 beds, the qualifications of a social worker are pretty stringent, and they are not going to be cheap for the facility to employ, but you have to have one. They have to have a minimum of a bachelor's science degree in social work or a bachelor's degree in human services field. And those can include sociology, gerontology, special education, rehab counseling, and psychology. And they have to have 1 year of supervised social work experience in a healthcare setting working directly with individuals. So besides having that degree, they also have had to have at least 1 year of supervised experience. Now, if you don't have 120 beds, I flipped through there once. If you don't have 120 beds, then you don't need to have the social worker, the bachelor degree supervised social worker. That's why so many of the facilities have the activities and the social services combined into one. I think that we've pretty much talked about everything I can talk about right now for activities and social work. Social services. I'm sure I could probably go on and on and on and have lots of neat stories, but this basically gives you an overall look at what the activities director and the social services director and their programs have to do with the quality of life and the quality of care for the residents in the nursing homes. If by any chance, sorry, I'm not there with you. If by any chance anyone has any questions, if you would let Z know, then he can maybe email those to me and I will see what I can't do about getting some answers back to you. In the meantime, I hope that this has been valuable information and that you have learned at least a little something from today. If there's anything that we can do at the State Department of Health in our long-term care facility, let us know and we'll see what we can do. In the meantime, stay safe. Thank you.